It's a bit of an impromptu one today. Yeah, appreciate you coming, and we'll get started, I suppose. Today's session is on breaking bad news. This is a good one to start off with in terms of like the more specific complex cases, just simply because there's such a small pool to choose from. But let's start with the presentation then. So yeah, that's what we're covering today. We're either going to be talking to the relatives about their condition, about the condition of their loved ones. Could be the son, could be the daughter, could be the wife, could be the husband. Or we're talking to the patient directly about the results. That's the HIV and the breast cancer ones. And yeah, just how we mentioned that these two can be virtual consultations as well. Just a reminder of the basic structure for spikes. Setting, I've just put grips in there as well. Yeah. So just a few things to bear in mind with face-to-face. It may be, especially, if they're an anxious patient, they might be standing up. So it might be worth, if they're quite anxious, they're eager to ask some questions about how their husband is doing. So I think it's, might be worth asking them to take a seat, make sure that you're both at the same eye level. And obviously no smiling for these kind of stations. In terms of the virtual ones, it's the same structure as before, but we just need to double check that they're in a private space. And just double checking if they need to move anywhere a bit more private. I think that's worth adding to your structure there for your virtual consultations for these kind of scenarios. And then and then voice tone for telephone in particular is very important. So we need to come in at the right tone from the beginning so that they kind of don't get shocked, so they kind of suspect there might be something going on. They should always have, I think they should always have a clue that something's not right from the beginning based on your tone. They shouldn't be surprised, It should be congruent. Your tone should be congruent throughout to the situation and the outcome that you're about to, or the news that you're about to give them. So yeah, the 3 Ps, so position, I understand that, which is, I think, what we're going to be using for most of them, but I think there's also the intracerebral hemorrhage one. So if you're calling the son, you'll be calling them out of the blue. And you'll be, alerting them about the fact that their father's in hospital because they don't have any idea about that. So you might need to, say something a bit different, something like, I'm sorry to call you out of the blue, and I apologize if this is an awkward time, because you've not met this person before, you've never spoken to them before, just a relative of the patient that's come into A&E. So I understand that might not be appropriate there, but then otherwise pretty much the same. So, the reason I'm calling, or the reason I'm, I've asked to see you, is to give you an update about your results, or to give you an update about your mum's condition. Or in the case of the intracerebral hemorrhage, where it's collapsed and brought into A&E, to let you know that your father's been admitted to hospital. So that one's a bit of a misnomer, that one, but the rest all follow the same kind of structure. And then I've just added this in here because sometimes it is good to give a little bit of a general status of the patient, because the patient will have questions. When you tell them that your father's been admitted to hospital, their first reaction is going to be, how is he doing? What happened? So you want to give, just the brief details at the beginning and then give more detail later on. So unfortunately, your father collapsed and was brought to hospital unconscious, or unfortunately, your son is not doing well at the moment, if it's the RTA scenario. So with the RTA, they know he's had an RTA, they were there, right? And then prior understanding is the same as the P for perception and spikes. So we'll get into that one. So I think this is important before we go into details, because we need to instruct the patient about the structure that we want to use. We need to, let them know that I'm not going to talk about his condition now. I need to ask a few questions first. So I think that's very important that we do that, even if, the patient or the relative is asking, what the results, or they're asking, how's he doing? Let's insist that we go straight into asking a few questions first, and then we will, by all means, provide answer all their questions. So before we go into details, can I just check what you've been told so far about your relative's condition or about your results? And then I like to ask a general question, an open question to start off with, and then a more kind of closed in one that really kind of closes in on what the news is you're going to give them. So if it's a breast cancer diagnosis, you want to know what was it explained to you, what it was exactly we were looking for in the biopsy, or, what the different possibilities of what this could be. Or if it's a, bilateral stroke, has anyone spoken to you more recently about the second stroke? Because they are aware that they've had a second stroke, but they don't know any details about that. So that's kind of the their position. So you need to ask them specifically about that, because that's the news we're going to be giving them. And the same for, the post-operative ones, did they explain the possible complications of the surgery to you? Yeah, and then the RT way, did anyone explain what investigations were being done? So, if it's a pelvic X-ray and he's sustained a pelvic fracture, if it's a CT scan of the head, then that's the one you're expecting them to answer. If they don't, then you need to explain that CT was done. And then history. So yeah, relevant history. So there is time to do quite a decent history, actually, because most of the time is spent on answering questions and delivering the news and the history. I think they're like the three biggest parts going over these cases. And so, I was quite surprised that you do have time to go through quite a decent history. At least FMAM, your allergies, your drug history, your past medical history, and some relevant social history questions. Usually who's at home is a good one, but there is time. So if it's a ICH or RTA, an incident history before, during, and after, and then you can ask them about any presentations. So with the breast one, it was a routine checkup. So you can ask them, did you have any symptoms? What was it that first led you to get investigated for this? Or did you have any symptoms at all that led you to see the doctor? She'd be like, no, I was absolutely fine, and I always examine myself all the time and I never noticed anything. But I came in for a routine checkup and they told me there was some abnormalities in the X-ray, in the mammography. So I've had a sample taken from my breast. And then you might want to do the ample history. So ample history is just the same as FMAM, family history, medical history, allergic history, and medication history. But just add on to there the last thing that they ate or drank. So when was the last time you had something to eat? When was the last time you had something to drink? And E is the details of the event, but that's already covered in incident history. I think that's fine. But for RTA, you might just want to do this just to save time. That will kind of cover you for the whole incident. And then your MAFTOSA, which we talked about. Open question, specific question related to the news you're about to give, and then history. That's perception. And then invitation, just two quick things to ask. I won't spend too much time on this. Just, it's good to get it out of the way. I think this is quite a difficult one to articulate in a way that gives the impression that you want. I think you want this to come across as, when you're asking them if they want, would you like anyone else to be here while we deliver the results or while we talk about your relative's condition? You don't want it to come across as if you're doing it because it's bad news. You're just doing it. It's neutral. You're doing it because it's an important thing that, loved ones should be around for, regardless of what the result is, or perhaps, to help with the understanding, or someone that might want to be there and might have some important questions to ask. That's the angle you want to approach it, not as in, because this is really bad news, you might need someone to support you. So I've mentioned support, but it's more another eye from somebody who has an interest in the relative. So that's that one. Would you like anyone to be here as well to discuss the results? And are you ready to go over the results now? Right. So these are this is the knowledge section. So we're using a layered approach, right? I'm going to start off with a warning shot, which is this kind of, unfortunately, I don't have good news to tell you. Then give the next layer of information. Pause, let it sink in. Assess for any cues. Assess if you need to stop. If they're crying, offer a tissue. Say, I know it's really upsetting news. I know it's distressing. Offer them tissue. Wait a little bit. Ask them if they're happy to continue. Just that kind of rhythm. I think it's good to to practice. It does take a while to kind of get your hang around the rhythm of it. And the thing is that these actresses and actors will be trained to do that. They will be crying and quite realistic in the way they respond. So there will be times where we'll have to pause and just wait and let them recollect themselves, calm down a little bit. And then once you've gauged that they're ready, you can ask them, are you okay for me to continue? So yeah, in layers. But before we do that, give a brief background, give a sequence from the hospital presentation, and then give that final step, whatever the investigation is that was done or was taken to the recovery room. And then we can pause, and then we can deliver the news. Unfortunately, I don't have good news to tell you. Not in that tone, but unfortunately, I don't have good news to tell you. The CT scan shows that he has sustained a bleed in the brain. Pause. Assess her reaction. She looks like she's okay to continue. Okay. And I'm sorry to say that the bleed is a major bleed. Your father was reviewed by the neurosurgeons and they agreed that, unfortunately, he is unlikely to recover from this condition. And then what does that mean? So you need to elaborate. By this, I mean that he's unlikely to survive the bleed in the brain. What does that mean, doctor? By this, I mean, unfortunately, that your father is likely to die. It's a similar approach to the bilateral stroke as well. What does this mean? By this, I mean, he's unlikely to survive. By this, I mean that he's likely to die. So unlikely to recover, unlikely to survive, likely to die. And the same for bilateral stroke, except for bilateral stroke, we'll need to add in even more layers about, they've outlined the details of what they want you to say in terms of the palliative care. So we need to give a bit more detail about palliative care, talk about, do not do CPR, and we won't be doing any assisted ventilation as well. So we'll include that too in there, and we'll include a bit more information about palliative care, what that means. And that will be in layers as well, because here we're not just saying that they're unlikely to survive, they're going to die, or they're likely to die, but we're saying we're not going to try and save him because we don't think it's in his best interest. So that's the kind of idea behind that one. The RTA in the child. So unfortunately, the CT head or X-ray shows Joshua has sustained a bleed around the brain or sustained a fracture in the pelvis. He was reviewed by the neurosurgeon or the orthopedic surgeons who decided that he will need major surgery. Fracture is unstable and he will need major surgery. So that's the next kind of shot that you're going to hit them with, is that it's major surgery he's going to have. So not only has he got this big injury, but he's also going to need urgent major surgery. And then finally, he's being prepared for surgery right now. So that's in layers. So we're going to pause in between each one of those. Breast cancer, when you're checking their understanding, what they know so far, they might say that they were told one of the possibilities is that it might be early stage breast cancer. So you might want to include that in when you're delivering the bad news. You mentioned that they told you it could be early stage breast cancer. I'm sorry to say that is what the result shows. I'm sorry to say that you do have breast cancer. I would try and, be direct with that. Even though it is an early stage breast cancer, I would start off by saying breast cancer, personally. But, I think other people might approach it in a different way. For the HIV one, I think giving them the normal results first, because you're going to have to explain what tests were done here. All the different tests that were done, the blood cell tests, the liver and kidney function tests, all that kind of stuff. And you're going to explain that the chlamydia test was negative, the blood culture was negative. That was negative. However, there was another test done for HIV. And I'm afraid to say that both the HIV tests came back positive. So that's the big news. So warning shock, and then deliver it in layers, big news, and then extra information. So after the big news, that's definitely where you need to have a pause, that one there. If you're only going to pause once, that's the one to do it. And then post-operative bleed. So this one is a bit different in that it's not an investigation result that you're giving them. So it's just a complication. The last step was they were taken to the recovery room. So up until now, operation was fine. Everything in the documentation was fine. There were no issues or concerns raised by the surgeon in the documentation. So, however, he developed a secondary hemorrhage. And we know that that can happen when the blood pressure drops, the temperature rises, any kind of problems there, they can manifest then afterwards whilst they're in the waiting room. But they do mention in that there wasn't a mistake made. And so, especially with the postoperative bleed, the lady will insist that a mistake was made by the surgeon. You can be quite confident in saying that there was no mistake made. This is a known complication of the surgery, and this can happen. We are operating on the major vessel of the body, the aorta. This is a well-recognized serious complication of this operation. That would have been explained to your father beforehand when he was signing the consent form. And then the same for the stroke as well. So I'm sorry to say that the scan shows she's sustained a stroke as a complication of the brain surgery. And then the next layer, I'm sorry to say that she's in quite a serious condition. She's been transferred to the ICU for close monitoring before she's reviewed by the stroke specialist. So throughout this, by the way, we should be assessing for emotion. If they do cry, acknowledge, I know this is really distressing news. Give them a tissue and then wait for them to compose themselves and then restart. Practice, that rhythm of doing that. You might need to do it more than once in one station. In some instances, they will make the patient cry throughout. And so you won't be providing any more information at all for the rest of the consultation. You will stop there and just be waiting for them to cry. And they're testing whether or not you're going to start providing more information whilst they're still crying, because you shouldn't. do be wary of that. That can happen only once they've started crying, and it's obvious that they're ready. You ask them, are you okay to continue? And then you deliver the extra information. Obviously, don't offer tissue if they're not crying. So that's just a general overview. It's probably quite a lot to take in. I think we should just probably get started, really. Yeah, you might want to definitely practice though the using the Eve protocol, ones that work for you. I do like upset, so I can see that you're upset because that kind of covers you for most of them. But for the RTA one, worried might be, or the postoperative complication, worried or in shock. Those kind of ones might be more appropriate. And then for validate, I do find this one quite a useful one, so I put that one first. I know it's quite a lot to take in at the moment, but then also it's a very difficult time. That might be one, for the more palliative ones, that might be more appropriate. And then for the kind of unexpected ones, not what you expected. And obviously you can use more than one, pick and choose. I'm sorry for what's happened, and we're here to support you through this. And then from there, you can talk about the support. A good one is, take me through what's going on in your mind. That's a nice one. Nice question to ask as an opening into exploring the emotions, or just how you're feeling. But definitely do ask the question, how are you feeling? Or take me through what's going through your mind. And then based on what they've said, I can see that and go into your protocol. So we're here to support you through this. So how are we going to support them? Well, first and foremost, they'll be receiving the best possible care. Your father will be receiving the best possible treatment or care, or you will be receiving the best possible treatment. Why is it the best possible treatment? Because it's with our best specialists, a very experienced breast surgeon, experienced vascular surgeon. What is it they're going to do? So in the RTA, surgery to remove the blood collection, if it was an epidural hematoma. By the way, for epidural, I wouldn't say bleed in the brain. I would say bleed surrounding the brain. For the intracerebral hemorrhage case, that is a bleed inside the brain. I do think it's worth making that distinction because the prognosis is different, right? That gives a more accurate picture, and it's perfectly fine to say that to the relatives, I think. So surgery to remove the blood collection, I wouldn't say hematoma. Palliative care, so that's a form of treatment as well. So when they ask, are you going to do anything? Have you given up on them? No, we're not. We're going to be providing palliative care, which is what the team of specialists in the meeting have decided, in the MDT meeting, have decided is in the best interests of your father. So we will be providing treatment, and it's in the form of palliative care. So that's fluids, pain relief, or any other medications they need to make sure they're comfortable, they're free from suffering, free from distress, free from pain, as comfortable as possible. And then surgery for the RTA to stabilize the fracture. And then for the postoperative complications, or the bleeding complication, re-explorative surgery to find the source of the bleeding and to stop it. The breast cancer one, you can talk them through the different types of surgeries, the 3 different types: lumpectomy, mastectomy, double mastectomy, and that the breast surgeon will take you through those and the pros and cons of each. The one that they do is based on their assessment they're going to do, based on scan results and the staging and all that kind of stuff. For the HIV that we're receiving this, it might be worth explaining that you will need to take this medication long term, because unfortunately, I'm sorry to say, HIV does not have a cure. As of 2023, there is no cure for HIV. So unfortunately, they will have to be taking this medication long term to prevent the onset of AIDS. I would encourage family involvement at this point. If you've told the son, and it's a family of 6 people, so they might want to speak to somebody else and let them know about it, and you can offer us to call them. So I would include that here. And then really it's the support groups. So I think the main ones there are HIV and cancer. Living with HIV or something like that. And then the main one for the cancer ones, which is useful, I think, for all cancer cases, is the Macmillan Cancer Support Charity, mainly a team of nurses who offer psychological, emotional support. That's throughout the journey, from the beginning. And then there's Mary Curie Charity, which is more the terminal cancers. That's another charity that's used as well. They're the main kind of support groups that we should be aware of: Macmillan Cancer and Mary Curie, MARIE CURIE. And then this is important. This is kind of like the equivalent of safety netting for breaking bad news, is any concerns that they might have. You've just, bombarded them with this quite distressing news, and there's a lot to take in. So I would say, I know it's a lot to take in at the moment, but do you have any questions for me at this stage? See if they have any questions. They might not be able to think of any right now. So we should acknowledge that, okay, if they do have questions, by all means, obviously answer them. But if they don't, or if they've got no more questions, I know it's a lot to take in. You may still later have some questions that you can't think of right now. So anytime, please don't hesitate to come see me, come ask to speak to me, call me, here's my number, or member of the team, and call the ward if there's anything you want to discuss. If there's any questions or concerns you have at any moment, we'll be glad to help. And then leaflet, I think for breast cancer, definitely leaflets would be a good one to offer, and HIV. Yeah, so that is the approach. So yeah, definitely have those. Make sure you practice all those before the exam, and we'll have that station in the bag. 11s and 12s, hopefully. So I think that's definitely why we're concentrating on these ones now, because it's such a small pool. Next one we'll be doing is medical errors, which is similarly, I think there's even fewer cases there for that one. So yeah, definitely let's focus on these and make sure we do these really well. Right, so